Okay. Dear participants, my name is Gab McDonough, and I'm the Educational Action Supporting Officer at ERN-EuroBloodNet, the European Reference Network for Rare Hematological Diseases. And it is my great pleasure to welcome you to the ERN-EuroBloodNet topic on focus on constitutional thrombocytopenia, which is an accredited European educational program targeting health professionals organized by the ERN-EuroBloodNet and in partnership with the CRPP, which is the French Reference Center for Inherited Platelet Disorders, and the Filière MHEMO, the French Constitutional Bleeding Disorders Network. The program consists of a cycle of webinars focused on constitutional thrombocytopenia, developed in collaboration with 3 experts, Professor Marie-Christine Alessi, Dr. Paul Saultier from Assistance Publique-Hôpitaux de Marseille, who's also a member of the ERN, and Dr. Mathieu Fiore from CHU Bordeaux. Before we start, let me just share a couple home rules. Please note that this session is being recorded and will be uploaded to our EuroBloodNet e-learning environment. If you do not wish to appear, please turn off your camera and change your name on the platform. Also, be very kindly informed that your microphone is muted. Be sure to keep this off. And if you have any questions about the presentation, please write them in the chat and they will be addressed during the Q&A session at the end of the webinar. Today's speaker is Dr. Roseline Dorheim, and the topic is the management of heavy menstrual bleeding. Dr. Roseline Dorheim is currently a medical director at the Reference Center for Haemophilia and Rare Congenital Bleeding Disorders at APHP, Université Paris-Saclay, at the Hôpital Bicêtre in France. Her research interests are primarily in the area of hemophilia, von Willebrand disease, congenital platelet diseases, and rare bleeding disorders in both children and adults, especially regarding women and girls with bleeding disorders, new therapies, issues in carriers of hemophilia, and Glanzmann's thrombocytopenia. She is the current elected president of the steering committee of the National France COAG Registry on Bleeding Disorders and also vice chair of the board of the PEDNET Registry. She is also a former elected member of the European Association for Hemophilia and Allied Disorders, the EAHAD Executive Committee. And with that, I hand over the floor to you, Professor Dr. And it's a great honor to have you here. Thank you very much.
Thank you so much for the very kind introduction, and thank you so much to the organizing committee for this kind invitation. We'll try to share my screen. Can you confirm that you can see the slides? Okay.
Perfect. Thank you.
Thank you. So among all these webinars on constitutional thrombocytopenia, the topic for today has been considered regarding what may happen to women and girls presenting this condition, and especially about the management of heavy menstrual bleeding. These are my disclosures. I think you already had these practical issues before we start. And the learning objectives for this webinar will be to help you to recognize what are abnormal uterine bleeding, which is the new formulation and nomenclature that we use for previously heavy menstrual bleeding. We will come back to that later. And also to properly appreciate the impact of these heavy menstrual bleeding, or AUB, on the quality of life. The second objective would be to be able to incorporate women-specific outcomes for women and girls with constitutional thrombocytopenia. And finally, to understand the potential areas of improvement, as for example, anticipation, prevention, and treatment of AUB in constitutional thrombocytopenia, including the value of the principle of care for women and girls with bleeding disorders and the management of these patients within joint clinics between gynecologists and hematologists. What will not be addressed during this webinar, as a lot of other extremely interesting webinars have been already scheduled or will be scheduled at the end of this educational activity, will be thrombocytopenia, for example, Glanzmann thrombocytopenia, the description of the different types of constitutional thrombocytopenia, because I know it has been fully addressed previously in other webinars, pathogenesis, the diagnosis process and the diagnosis issues, the syndromic features associated in some of these congenital thrombocytopenia, and the malignancies predisposition. We will not talk either about pregnancy and postpartum hemorrhage, as a specific webinar will come later. And I will not only talk really on a very specific hemostatic treatment. These will be teasing for other webinars. However, we will have today extensive topics regarding how to manage heavy menstrual bleeding and or abnormal uterine bleeding in congenital thrombocytopenia. Our first point would be, as a disclaimer, that we refer here in this webinar, in this presentation, to women and girls, but the concepts apply to all menstruating people. The main chapters will be a few words about prevalence and demographics of congenital thrombocytopenia. Then we will go a little bit further into details about abnormal uterine bleeding in congenital thrombocytopenia, how to recognize them, how to evaluate them, and also to learn how to incorporate women-specific outcomes in the day practice. What would be the management of abnormal uterine bleeding in those specific patients, and factors that may affect the severity regarding the specificity of this disease. Let's start with demographics. So these data are coming from the World Federation Haemophilia annual global survey. As you know, every year each country may contribute to this demographic data. And this record is from the 2021 survey and comes from 118 countries. And you have a global picture about all the bleeding disorders recorded in the world of these countries contributing to this survey. As you see, we are reaching nearly 400,000 people with the bleeding disorders. For those who have documented the sex known, either male or female. The majority of these patients do have hemophilia. This is the blue square here. And the second one in number will be the von Willebrand disease, something like about 90,000 people. And you have the rest of the people who have numerous different defects called the other rare bleeding disorders or other bleeding disorders, which represent about 16% of the global population. And among them, you will have the rare factor deficiencies, factor 5, 10, 11, 7, etc. And you will have the platelet disorder. This is the yellow square here that you can see, which is about 22,000 people recorded. And you have a new category that has been introduced recently, which is the bleeding disorders of unknown cause, which is a category which is increasing. The platelet disorder represent a bit below 6% of the global demographics. So we are here in the very rare of the rarest bleeding disorders. You have here from the 2020 global survey, again from the WFH reports, the evolution of the number of all bleeding disorders recorded so far in different countries contributing to this survey. And on the right side of the figure, you have the distribution of the identified patient over time by type of bleeding disorder. And you have the category regarding the platelet disorders, which is in blue and here in brown and a little bit of purple here. So these are the category included in the platelet disorder, and you see that the recognition of these disease is with time increasing, and more people are now diagnosed. If you now look by distribution, by sex and type of bleeding disorder. The majority of the patients recorded are men. About 25% of the people recorded are women. And the platelet disorders represent a very small majority, very small proportion of the global, as we have already said. If you look now at the bleeding disorders in women recorded in this survey, the majority, about more than half of them, do have von Willebrand disease. And the platelet disorder, here in yellow again, is in 2020, it was about 7,000 women, which is really a very small proportion globally. But that's improving, and diagnosis probably is increasing. Now you have the result from the 2021 survey, and you already have much more as we are reaching now above 12,000 women recorded. So progressively, we see that these recognition are increasing. However, the disparity about the definition here in this survey has to be emphasized. So when you look at other registries or data collection, the definition might not be the same. So that's an issue, not to have harmonization of how these platelet disorders are actually recorded and really categorized. What we can say about women and girls with bleeding disorders in general, but that could, I think, totally apply to those with congenital thrombocytopenia, is that these girls and women face additional and specific challenges. And you also have a lot of disparities in access to both diagnosis and treatment of their bleeds. And usually the diagnosis is quite late in life, despite the occurrence of bleeding disorders during childhood. And a lot of lack of knowledge is observed, not only from the patients and the families and the patient organization, but also among healthcare professionals, and especially for the non-specialist healthcare professionals. The reason for that is that usually when there is one person diagnosed, the family inquiries are not usually performed in detail and on a yearly basis, an update of the family trees, for example. This is also very difficult sometimes to have some discussion within family members in order to motivate those who potentially are also affected to come and to seek for medical advice. Another problem is that the bleeding symptoms sometimes might be in a congenital thrombocytopenia quite mild, and the recognition of what is a bleeding which is considered by hematologists as abnormal is not that simple to recognize for patients. This is particularly true for acute uterine bleedings. Another problem is that during pregnancies, the options that might be applied are usually unknown, and the risk not only for the mother having the bleeding disorder, but also for the fetals is not completely well understood and known. And this is contributing to the absence of coming to the clinics to have information and counseling. And finally, I think that if we looked specifically at acute uterine bleeding, the impact on the quality of life is largely underrated, including by healthcare professionals, and I must say also including by hematologists. I think that sometimes we do see those heavy menses and heavy menstrual bleeding as something which is quite common, not specifically acute sometimes, and the burden of what is represented by the frequency, each cycle, every month, and also the intensity of the bleed, and also what is related as well as the pain and fatigue is totally underrated usually by the healthcare professional, and we do have to progress in order to better recognize these impacts on the quality of life. I think if you have the opportunity to read that paper, Everything Was Blood, when it comes to me, some concepts are regularly seen in women and girls with bleeding disorders and could particularly apply to a patient with thrombocytopenia. A lot of uncertainty around the diagnosis is frequently reported. The experience through family bleeding histories is not well understood among the families. A lot of women do report an intensity of the bleeding symptoms in terms of impairment of the daily activity, either school, either work, and this is really impacting frequently the daily life of these patients. And I think that also the difficulties to diagnose those women who do have a bleeding disorder need also from our side to improve maybe the communication that we have with this patient in order to better help them to differentiate what is normal or what is abnormal bleeding, and try to use symptom recognition-based language, which is easy to understand from people who are not from a medical field. And that could be tested early in order to have accurate and early diagnosis, which is another problem with thrombocytopenia, because as you know, a myriad of different type of pathologies are not always very easy to diagnose, and sometimes requires a lot of time before you get eventually to the diagnosis. It can take a lot of time. So if we now dive into abnormal uterine bleeding, I will start with what is the challenges in measuring those abnormal uterine bleeding. In the general population, a lot of persons, about half of them people from an online survey that has been performed a couple of years ago in France. About half of the people said that they do not know that menstruations may induce medical issues. About a third consider that pain is normal during periods. The majority of them, 66%, did not receive any formal education about menstrual cycles. It remains a societal taboo for a large majority, and especially in the young groups of people who were responding, 69% of the group between 16 and 24 years. And there is always reported difficulties distinguishing what is normal and what is abnormal menstrual cycles. Now, if we move to the field of abnormal uterine bleeding, it really is a medical issue of public health. A lot of women are do have this problem. About a third of adolescents and about 20% of adult women during the reproductive years. There is a lot of hesitancy among women to seek for medical support, so they will miss the diagnosis, and that will contribute to the delay in the diagnosis. If we looked at the person who are coming and to come for a first visit because of this symptom of abnormal uterine bleeding, about 1 out of 4 or 1 out of 5 women with AUB is concerned by a gynecological disease, and about 20% of them are concerned by a bleeding disorder. The problem is that you also have about half of these women do not have an identified cause, and this is also complex for us as hematologists to differentiate between what could be platelet disorder that can be identified or something else, and so that's always a question which is sometimes very difficult to handle. If we look a little bit at these quite old data, because that's coming from 2010, and that's coming from the US, the prevalence of bleeding disorders in girls and women that comes to a clinic because of a symptom of IUB. According to different publications, you may have a platelet dysfunction in less than 1% of the women, but up to 47%. And for adolescents, it would be between 2 and 44%. Now, if you take the problem the other way around, what is the prevalence of AUB in a girl or a woman already identified with a bleeding disorder? You see that for the platelet dysfunction, this is a high prevalence for those who have a severe platelet dysfunction like thrombasthenia, Glanzmann thrombasthenia, or Bernard-Soulier syndrome. And you have a large heterogeneity among the other platelet disorders. What we can say regarding the platelet disorders is regarding the thrombocytopenia, the presenting symptoms is mainly mucocutaneous, and the severity is highly variable. But the majority, if you put apart the Glanzmann thrombasthenia, which is the thrombocytopathia, and the Bernard-Soulier, which is associating thrombocytopenia and thrombocytopathia, the majority of the other platelet disorders are usually milder ones regarding the presenting symptoms. Of course, the bleeding is not in the context of congenital thrombocytopenia, the highest severity sometimes, because those thrombocytopenia who do have other associated syndromic complications and risk of malignancies, for example, that will lead to another severity for health. And this is why this is very important to have a precise diagnosis of those. The exact prevalence is unknown because the disparity among the different labs and according to different countries is extremely high. But we know that obviously for those defects that are autosomic recessive for the transmission, you can see a higher prevalence in case of high consanguinity. The diagnostics remain quite complex, as I said, because of the myriad of different congenital thrombocytopenia. And it may take a lot of time in order to get the diagnosis. It's also very important to emphasize the pre-analytical variables that may impact the diagnosis, as dietary, drug, herbal factors that may also contribute to misleading diagnosis. And ISTH is working on algorithm in order to help the laboratory diagnosis. And the revolution came from the genetics here, and a lot is helping us, as you know, from the NGS approaches or the whole genome approaches that will help, we hope, in future to better diagnose those patients. Regarding the AUB, for the severe thrombocytopenia like Bernard-Soulier syndrome, it has been described up to 50% of the patients that do have bleeding problems during their menses. About almost all the Glanzmann thrombasthenia girls do have problems at one time or another of their reproductive life. Sometimes it is an acute major bleeding at menarche, which is very difficult to manage and has to be anticipated for adolescent. But you may also have other complications like cyst rupture bleeding also. All of these will impact the fertility and also the pregnancy management. but in majority, in the milder platelet disorders, the incidence of AUB is quite different from one group to another, from one publication to another. So we do lack a lot of data here in order to have a real picture of what is really happening in order to have an appropriate response regarding the treatment. As I already mentioned initially, in collaboration with the gynecologist, it is now proposed to use the term abnormal uterine bleeding instead of all the other words that you can see on the left of that slide, including heavy menstrual bleeding. The purpose of this was to have a broader definition of what is the impact that may have this increased flow during menses. And so the definition is excessive menstrual loss, which interferes with physical, social, emotional, and or material quality of life. With this definition, you have, for the most severe patients like Lanzmann thrombocytopenia, up to nearly sometimes 100% of the patients that do express heavy menstrual bleeding, but you also have lighter impact in some publication. So I think that the variety as well of what has been used as definition of acute or abnormal uterine bleeding may also impact those incidents. So why would it be important to move forward in order to have new tools to better measure the outcomes in women and girls with bleeding disorders, and especially in those who have thrombocytopenia? I think that's very important to have standardized approaches that will be pivotal in order to address the specific needs in those patients, and needs also to be appropriate at every stage of life. And this is very important in order to have accurate and early diagnosis, to manage properly, and to follow up also the patients during all of these years, to understand also the patient experience in order to better tailor the treatment options, and to measure as well when new molecules or new treatments will come, what will be the actual efficacy of innovative therapies for current or for future clinical trials. So in that context, you all know what is the pictorial bleeding assessment chart, or PBAC, that has been developed with Professor Jenny Higham, who is a gynecologist. And you all know this menstrual chart that you explain to the patient how to fill in, and that this is the original menstrual chart and scoring system, and called the Higham score. And it is supposed to be collected every day, the number of protection that was needed for the patient. And at the end of the cycles, you may come with a calculation. And if you are above 100, which means probably above 80 milliliters, it will be judged abnormal. However, this tool has been used mainly in clinical trials, but that is challenging in order to do it in a standardized way, and the applicability in primary care is not that simple. Indeed, if you look at the literature, multiple examples of PBACs have been used and developed. Sometimes you have different number of points according what a full tampon or a towel is. It could be 10 or 20 points. Sometimes you may have more than 3 different levels in the type of protection, up to 5. Sometimes the clots are not included, sometimes they do. Sometimes you have different scoring according to the size of the clots. Sometimes the fluiding is rated, sometimes it is not rated. Sometimes you add other informations like regarding during the day or during the night, records of pain, etc. Sometimes it might be also difficult to use these tools with the modern menstrual products like cups or pens. And you may also have some missing symptoms not recorded in that tool, like mood, tiredness, fatigue, pain, etc. Another example also has been described in the literature, saying that even if you have a PBC below 100, which is supposed to be normal, sometimes you may have some impact on the quality of life that can be reported by the person. So this is not a unique tool, and that is just to emphasize that probably we need to have better tools, even if this tool is very useful on the daily practice as well. So it is in the other bleeding assessment tool also important to know what is the scoring that is used regarding menstruation. And when you look at all the different locations of the bleedings, you come up with the ISTH bleeding score. And you have here the normal range or the abnormal score for a woman adult. Currently, it is abnormal if you are scoring 6 or more. And for children, if you are scoring 3 or more. And you have here the definition within that ISTH BAT of 1, 2, 3, or 4 points, according to the description here of treatments or some of the clinical symptoms. But all of these tools do have limitations regarding sensitivity. It's also is reported that you have a lot of recall bias, that the score might be saturated when you have recurrent symptoms, so it is not always reliable. And it might be difficult to differentiate between mild to moderate bleeding disorders just based on these BATs. The ISTH considered maybe to modify regarding this variability of ISTH BAT with age, and is exploring potentially refinement of the level of what is normal and abnormal regarding age in women. But these needs further exploration and validations. If you look at what has been done in other disease, it remains symptom recognition-based language as proposed for the VWD ISTH recommendation. It's not that simple in practice either. And even if we have some kind of items and words that are proposed in this regard for application to the VWD, we all have our own words when we have the clinics with a woman in order to recognize what is the AUB. This is what we are doing from the hemostasis part, but if you have a discussion with our colleagues from the gynecology, they have been working on the FIGO system, which is the International Federation of Gynecology and Obstetrics, who is scoring the abnormal uterine bleeding in different types of causes. So the system is called PALM-COIN for polyp, adenomyosis, leiomyomas, malignancies, and hyperplasia. And we are concerned as by the from the hemostasis part, by the coagulopathy, and by the iatrogenic part as well. But when you look at the parameters that are used, frequency, duration, regularity, flow, indeed, only limited items are similar to what we are using in the ISTH BAT part of scoring of the menses. So I think that if you have here the example of the FIGO AUB system, and now you have the ISTH HWFH items that has been used for the VWD, we see that there are some similarities, but there are also a lot of disparities. And certainly we have to work together in order to, with the gynecologist, in order to have a better homogeneous way to recognize and score these AUBs. Apart from the BAT score, apart from the PVACs or whatever the version of it, there are new instruments that might be also useful that might be important to handle and implement in the regular practice. You have here 3 examples. One is the menstrual evaluation questionnaire. Another is the menstrual symptom questionnaire. And another one is the evaluation period impact and pain assessment, or PIPA. And all of these different questionnaires are multidimensional questionnaires that implement also some other parameters from patient-reported outcomes that might be important. And now a lot of research is currently using some of those tools and new tools, like, for example, a menstrual bleeding questionnaire, or MBQ, or specifically regarding some age groups as well. And these new tools really have to be better known and implemented in our daily practice. Some are validated in some disease. Currently in thrombocytopenia, congenital thrombocytopenia, there is no specific tool that could be as particularly appropriate, but that could be potentially a work that would be needed to be done. Finally, in order to record the AUB, an interesting work has been published recently using what kind of data we can get from the apps that are completed by the patient on their smartphones, and to compare the online surveys that has been done and what has been tracked by the app users. And I have no time to go into the details, but it seems that it may limit the recall bias. It may help to collect other items and parameters beyond the AUB, like pain, fatigue, digestive symptoms, mood changes, headaches, etc., that might be important also to record. And this may be helpful in order to better collect the satisfaction level and the compliance regarding the treatments that can be implemented. Now, if we move to the AUB management, you have here a list of the 5 pillars of the symptomatic treatment that can be useful for abnormal uterine bleeding. And to make happy your patients, you can remember that you will need at least one or a mixture of several of these potential tools, like hormonal therapy, tranexamic acid, painkillers, psychological support and education, and iron supplementation. These can be started before a specific diagnosis is made, because there are symptomatic treatments that may help to reduce the importance of the heavy flow and the consequences regarding iron deficiencies and anemia. And they may be effective despite the fact that you have not a definite diagnosis. They can be used alone or in combination. And when you have a diagnosis, that will be useful to continue these symptomatic treatment, in addition to potential specific treatment outside of the approval for some of them, like platelets, DDIVP, 7A, L-Thrombopac, etc. I would like to insist as well on the role of the first-line actors to contribute to early diagnosis of women and girls with bleeding disorders. And that is valid as well, I think, for patients with platelet disorders or thrombocytopenia. All of these potential first-line actors should be informed about what is normal or abnormal menstruation, and to record at least a few items, not a complete ISDH-BAT, of course, because that is difficult to perform for non-specialists, but to at least have some information about what is abnormal nosebleed, abnormal mouth bleed, abnormal postoperative bleeding, etc. And in case of doubt that might be a bleeding disorder, record as well the family history, make the first prescription, a blood count, an iron status, and potentially non-specific coagulation parameters. And if you have really a clinical potential suspicion of bleeding disorder, refer very quickly to the hemophilia or hemostasis specialist in order to have some work done. What is important as well, that these healthcare professionals could be empowered in order to start the symptomatic treatment, even without the diagnosis or before the first clinic. So that is important in order to help very quickly the impact and limit the impact of the abnormal uterine bleeding. A few words about one of these symptomatic treatment. Tranexamic acid is largely used and very effective, usually in the mild platelet defects. Sometimes it is not needed to add anything else, and sometimes it is extremely helpful. These tool has been described to be very effective in order to limit the duration and the number of changes during a day, and to limit the risk of anemia and iron deficiency. Just few words regarding the contraindication in case of active thrombosis, to limit this use in case of bleeding in the urinary tract. And epilepsy is not a full contraindication unless you use specific anti-epileptic drugs where the combination is to be avoided. But some epilepsy might not be a full contraindication. So please go and discuss with a neurologist in order to see, according to the type of epilepsy, if this is really contraindicated or not. Hormonal therapy reduces the endometrial proliferation and is also very effective. It prevents as well the hemorrhagic cyst. According to different countries, you have different habits of prescription regarding hormonal therapy. Usually for non-severe platelet thrombocytopenia, the combined estrogen plus progestin might be enough, or progestin alone might also be enough, and it is rare to move to such kind of difficult implementation or more severe situation. Importantly, it has been described some adverse events regarding high dose and prolonged treatment, continuous treatment with hormonal treatment. So that's important to be aware that these complications might exist. So one is the hepatic adenomas that has been described mainly in Glanson patients receiving this molecule for a very high dose and long time. And similarly, there has been described the description of meningiomas for prolonged and high dose of some of progestin. So now there are some warning and limited prescription in order to follow the label. We have to be cautious regarding dose and duration. A nice evolution is in order to help the management of the patient is the development of multidisciplinary clinics. A lot of centers do now have joint clinics between the hemostasis team and the gynecological team. This really is very helpful in order to harmonize the proposal of the different strategies, to organize the anticipation of the menarche, and to implement the follow-up of the menses. Because when you have the implementation of a treatment, it is very important to assess not only the efficacy, but also the tolerance and then the adherence to the treatment in order to prevent recurrence of those complications. Education here is really key. And in the discussion, especially with adolescents, a lot of taboos are sometimes behind the problem of adherence or acceptance of hormonal therapy, for example, but also of tranexamic acid. And so these has to be really explained, and in order to have the better option and a shared decision-making process with the patient in order to secure the adherence efficacy for a long time. These combined clinics is dedicated not only for girls already diagnosed with a bleeding disorder from reference centers in hemophilia, factor deficiency, or platelet disorders that need to be followed for anticipation of the menarche, and then the first menses, and then during all the menstrual life, but also for those who come for diagnosis in the gynecology department because of acute or abnormal uterine bleeding. And the question for them is, do they also have a bleeding, do they have a bleeding disorder or not? And this is to have these combined teams is helping diagnosis, to define a more simple care pathway, to develop therapeutic education of the patients, to help the follow-up, to discuss complex cases between the different teams, to program and organize research programs and projects, and to train other healthcare professionals like young fellows, for example, especially in the emergency rooms. Other options in order to help the management of these girls is to apply the European principle of care for women and girls with bleeding disorders, and these apply very well for the thrombocytopenia group as well. And there are specifically items regarding education and heavy menstrual bleeding that has to be developed. This is not only a principle that has been decided in different categories and chapter, but you also have some tools that has been developed in order to help centers to implement those principles of care. Sometimes also you have some development of national guidelines in combination with a gynecologist, and this is extremely helpful in order to help and ease the pathway and the care for these girls. And be aware as well that those girls not only have acute or abnormal uterine bleeding, but they also may experience pain, dysmenorrhea, hypo or infertility, hemorrhagic ovarian cysts, pregnancy-related concerns, which all of them will reduce quality of life. Hysterectomy is something which is recorded in women with bleeding disorders more frequently and usually earlier than in other population. I would like to share just one case of a pregnancy that has been observed in a patient who had a thrombocytopenia. She was 21 years old. She had been vaginally delivered but without any bleeding, with a wrong diagnosis of ITP, which is quite frequent in congenital thrombocytopenia. She had no response to IVIG. And it took 30 years in order to get the diagnosis. She still had thrombocytopenia, but then someone at least finally found the giant platelets and the dull leukocytes inclusion, which made a suspicion of MYH9 gene mutation that has been finally found in order to explain these features. And she had heavy menstrual bleeding for which she did receive an indication for hysterectomy. And she received a thrombopag in order to increase the number of the level of the platelets. And you have here the draft that could show that this increase of the platelet could help to perform the surgery without any complication and bleeding complication. And other affected members were in the family inquiries finally found. Research is also helping us a lot in order to identify the different variants and as you can see in the 50 patients that could be recorded with a different genotype, you may have some features regarding the bleeding symptoms, and that is very helpful to collect data in order to improve the care of these patients. And I will finish with just two slides regarding the fact that you may have, as you know, thrombocytopenia, congenital thrombocytopenia, non-syndromic. Usually they may have either no significant platelet dysfunction, and then the severity of the bleeding will correlate with the degree of the thrombocytopenia, but you may also have congenital thrombocytopenia that do have as well a platelet dysfunction, and this will increase the severity of the bleeding symptoms, and not only will be represented by the platelet count. So that is important to know. And finally, I will pass that one. A definite diagnosis for those who have a potential risk of malignancies really need a definite diagnosis in order to improve and identify the subject that, in spite of the mild or the moderate thrombocytopenia, are at risk of bleeding on the occasions of hemostatic challenges. And this is also important to record what could be the evolution of the thrombocytopenia over time, which may also impact the severity of the clinical features and symptoms. As take-home messages, I think that awareness is now increasing regarding those types of thrombocytopenia, constitutional thrombocytopenia, with an improved number of patients that are already diagnosed, including for women and girls. There are new outcome measures that need to be implemented for them in order to better collect informations regarding their daily life and health issues. And you have here a lot of fields of improvement regarding the description of the pathway of care, the development of joint clinics to help earlier and accurate diagnosis, to have some education program that can be implemented, and to develop research, data collection, and registry. With that, I will thank you for your attention. I will thank especially my colleagues from the Center of Reference of Platelet Disorders in France, and especially Marie-Christine Alessi, Paul Saultier, and Mathieu Fiore that has been organizing this webinar. Thank you so much.
Thank you for that excellent presentation, Doctor. And yeah, thank you to all the coordinators that are also present in this webinar as well. There's a question from one of the coordinators, Mathieu Fiore, if you have the time to answer. It says, Dear Roseline, have you ever used TPO analog to improve severe menstrual bleedings in your patients?
No, I do not have this experience. We only had some use of these type of drugs in order to secure invasive procedure that was planned. So we had the time in order to improve the number of platelets, but we do not have prophylactic use, I would say, of these drugs in order to help abnormal uterine bleeding. I don't know if any of the participants do have experience in that, but I don't.
Great, thank you very much for your response. Then we also have another question from one of the coordinators, Paul Saultier. Thank you so much, Roseline, for this very clear lecture. In your practice, do you use one of the new tools for evaluating AUB, such as apps? And there's a following question, if you would like to.
So if I understand well, the question is regarding the apps that can be used in order to record the AUB. Is that correct? Because I cannot see the question, so.
Yes.
Yeah.
Yes, correct. Yes, the apps.
Okay. That's a discussion with the patients, because even if we do have some apps that we think are nice, that collect interesting data and parameters, it is not that simple to change the habits of one given patient. So usually they have their own apps that they has been chosen for because they like the color or because they like, I don't know, the the design or whatever, or because they find it practical and easy to use. And so sometimes they do record some information that maybe is not informative for us. But certainly that would be, I was really impressed about the result of this publication last year, reporting the interest of such apps in order to be really reliable in terms of parameters recorded. So I always encourage the patients to use such kind of apps if they don't, and if they are happy to do so, but if they are okay with one app, I will adapt to their own choice of apps. There are quite numerous of them. Some are free, some are needing some payments, so it depends.
Yeah, thank you. Yeah, because the limits of the EGAM scores, including, for example, the modern protection methods that the young adolescents and young adults may use, such as cups or pens, as you mentioned, I think it will be a limit for using the current scores.
Yeah, I agree that this is not a 100% perfect tool. However, it is, when it is used, it is also interesting because for a given patient, using the same type of PBAC, this is really important because you can have the patient is his own control when you implement a new therapy, for example. So if you are using the same tool, that's also interesting, even if it is not, again, the tool that you would use. But more and more, the other health-related outcomes become really important to record. And we are aiming to have a better quality of life. So the quantity of the flow is not all. So I think that's also important to have these new tools to implement other health-related outcomes.
Thank you.
We also have another question from Beatrice Nolan. Hi, Roseline. Is there an educational program about menstrual health in French schools for adolescents?
I'm not aware about it. I think that's a good initiative that could be very interesting to implement. I'm not aware about that, no, of existing tool. I'm aware of local initiatives that are sometimes done in an area around a territory in some region, but not through that channel.
Great, thank you for your answer and for the question. At this point, I just wanted to make a quick announcement that the next webinar will be on October 23rd on Constitutional Thrombocytopenia, the management of pregnancy, which is an excellent follow-up to today's subject. And the speaker will be Remy Favier and Agnès Rubuzo. I will put that in the chat now. And I don't know if there's any last questions or if the coordinators would like to say anything. But just in the meantime, it's been a true pleasure to have you, Doctor. And thank you very much for this informative presentation.
Thank you so much.
Thank you all for joining. We look forward to seeing you next month. So please spread the good word and then be sure to connect next month. So thank you once again for everyone that's present, all the attendees, and have a wonderful evening. Thank you all.
Thank you very much. Bye-bye.